Good morning, good afternoon, and good night to our evaluator, which is Dr. Putu Santhi Dewantara, MBOmed Specialist T.H.T-KL, and to our facilitator, Dr. Putu Eka Widyadharma, S.Ked M.Sc. Now, here is our student project by SGD 8 Ramsay Hunt Syndrome. So, this is the members of SGD B8.
Hello, my name is Devi with the last three-digit number 005. I will explain about the introduction in Chapter 1. Introduction. Ramsay Hunt Syndrome is a form of acute herpes zoster that occurs from reactivation of the VZV or varicella zoster virus in the geniculate ganglion. The virus reactivation could cause inflammation mainly in cranial nerves 7 and 8. The clinical manifestation triad for Ramsay Hunt syndrome is vesicular rash, otalgia, and lower motor neuron ipsilateral phase paralysis. The early stage of VZV infection could cause fever and chickenpox. The virus will continue to exist in the body inactively or remain dormant after the initial infection. The virus's subsequent reactivation will cause a herpes zoster or zoster, and this syndrome often corresponds to a single dermatome and is characterized by pain and vesicular rash along the distribution of the affected nerve. The geniculate ganglion reactivates the virus along the seventh cranial nerve is called Ramsay Hunt syndrome. The Ramsay Hunt syndrome has an annual incidence of approximately 5 per 100,000 persons and can affect both the immunocompetent and immunocompromised person or patients. Ramsay Hunt syndrome should be treated in a combination with antiviral medication and steroids. The early identification of Ramsay Hunt syndrome is essential to improve the damaged nerves, and the origin, epidemiology assessment, and therapy of Ramsay Hunt syndrome will further discuss in the student project.
Hello, my name is Christian Sinaga with Trila student ID number is 096. So I will explain to you about the problem formulation. Is what is the definition, etiology, and pathophysiology of Ramsay-Hunt syndrome? What are the clinical manifestations of Ramsay-Hunt syndrome? How to make the diagnosis of Ramsay-Hunt syndrome? What are the differential diagnosis and the complications of Ramsay-Hunt syndrome? How to treat and how is the prognosis of Ramsay-Hunt syndrome? The objectives of this student project is to know the definition, etiology, pathophysiology, clinical manifestations, how to make the diagnosis, the differential diagnosis, the complications, how to treat, and how is the prognosis of Ramsay-Hunt syndrome. So I will continue about the benefits. The benefits of this student project for us as medical students include complete knowledge of Ramsay-Hunt syndrome, starting from its definition, etiology, pathophysiology, clinical manifestation, diagnosis, differential diagnosis, complications, as well as to find out the right treatment and its prognosis. The benefit of scientific learning is that we can learn more about Ramsay-Hunt syndrome and know how to treat it. The benefits of for the community include increasing knowledge in the community so that they have a better understanding of Ramsay syndrome and appropriate therapy for it. Next.
Hello, my name is Luina Saraswati with the last three digits of student ID number 142. Now I will explain about the definition of Ramsay Hunt syndrome. Ramsay Hunt syndrome is a rare disease caused by the reactivation of the varicella zoster virus in the geniculate ganglion. Ramsay Hunt syndrome is also known as the geniculate neuralgia or intermediate nerve neuralgia or herpes zoster or ticus. Ramsay Hunt syndrome is a rare but severe complication of primary infection with the varicella zoster virus, which generally affects children, namely chickenpox. Ramsay Hunt syndrome was first reported by neurologist James Ramsay Hunt in 1907, where he found several cases of erythematous vesicular rash on the auricular area or oral mucosa that caused by reactivation of the varicella zoster virus in the geniculate ganglion or facial nerve, which can sometimes be combined with some neurological disorder of the cranial nerves.
Okay, so hello everyone. I will introduce myself first. My name is Joko Desi Dedi Pemayun with the last digit number of 165, and now I will explain to you the etiology of Ramsay Hunt syndrome. So the causative agent of Ramsay Hunt syndrome is the varicella zoster virus, a member of the human herpes viridae family, and more specifically, together with herpes simplex virus 1 and 2, it is called HHV1 and HHV2. It is part of the alpha varicella subfamily. So varicella zoster virus is technically a double-stranded DNA containing virus better known as human alpha Fast virus 3 or HHV3.
Hello everyone, my name is Putu Eka and now I will explain about the pathophysiology of Ramsay Hunt Syndrome. The primary infection of varicella zoster virus causes the chickenpox or varicella, with symptoms of fever, chills, headache, and accompanied by a periodic fascicular rest. After viremia resolves or the infection ends, the virus resides in the cranial nerve neurons and the dorsal root ganglia. We can call this the dormant phase. When the immunocompromised condition, the previously dormant virus is reactivated. Reactivation of the virus produces the localized rabies vesicles, known as the herpes zoster, and in some cases progress the Ramsay Hunt syndrome. Reactivation of the virus in the geniculate ganglion of the facial nerve or cranial nerve 7 in the temporal bone is the pathophysiological mechanism of the Ramsay Hunt syndrome, and this process known as ganglionitis. Ganglionitis compresses the set of the nerve tissue, causing symptoms in the cranial nerve 7 or the facial nerve, make the paresis. And when acute infection of the ganglion in the inner ear and a spread of the inflammatory process of the cranial nerve 7 or facial nerve can cause the symptoms of neurological disorder nerve age, such as tinnitus, hearing loss, nausea, vomiting, vertigo, and nystagmus.
Greetings, my name is Felix Devanya Robajasomobis with the 3 last digit of my SIN number 113, and now I'm going to explain about the clinical manifestation of Ramsay Hunt syndrome, which a syndrome that caused by reactivation of the varicella zoster virus in geniculate or facial nerve. And this disease has two main symptoms, which is the first one is a red rash accompanied by painful blisters inside the ear, earlobe to the roof of the mouth. The second one is facial paralysis on the affected side, which make it difficult for the sufferer to close one eye, eat, and make facial movements. And the appearance of the rash and facial paralysis usually occurs only on one side, and it usually occurs simultaneously. And however, in some cases, facial paralysis is not accompanied by a rash. And also, due to anatomical association with other cranial bones, cervical spinal nerve, and various clinical features may be present, such as tinnitus, facial paralysis, hearing loss, nausea, vomiting, and also vertigo.
Hello, my name is Santhi Dewantara with Relast student number 163. The diagnosis of Ramsay Hunt syndrome can be done clinically and by physical examination. In clinical diagnosis, we'll find the classic triad, which are ipsilateral facial paralysis, otalgia or ear pain, and vesicles or rash on the auricle. The lab test is pretty much unnecessary unless only as a confirmation. MRI can be done in order to show a further imaging of the inflammation. Serologic tests will be done if only clinical signs and lab tests are not distinct enough.
Hello, my name is S.Ked with the 3-digit number 210. Now I'm going to explain about the differential diagnosis of Ramsay Hunt syndrome. Every serious outbreaks, staphylococcal impetigo, and contact dermatitis are some of the most common causes of localized facial rashes. Several cranial neuropathy can be brought on by both central nervous system pathology and viral infections like SARS-CoV-2. The most frequent non-traumatic cause of acute facial paralysis is Bell palsy.
My name is Vidya with the last 3 digits of student ID number 108, and I'll be explaining about the complications of Ramsay Hunt syndrome. So the short-term complication of RHS mainly occurs when there is an involvement to the eye, including corneal abrasion and exposure keratopathy. Corneal abrasion can cause substantial discomfort, photophobia, and also erythema, and exposure keratopathy can cause ulceration, microbial keratitis, and also irreversible vision loss. In addition to that, approximately 3% of those with Ramsay Hunt syndrome will fully restore their facial nerve function, marked by the presence of residual weakening or abnormal synkinesis of the facial nerves. There are also some Ramsay Hunt syndrome cases with more rare complications, including cranial polyneuritis, bilateral focal cord paralysis, and also cerebral venous thrombosis.
For the opportunity, now I would like to discuss the treatment of Ramsay Hunt syndrome. The first and foremost important thing of the goal of treatment is to prevent further complications and also exacerbations. That can be done through a set of medications that can be applied. The first of all, which is the most common, is to be given antivirals to actually reduce the effect of the host immune response. A typical regimen would include an acyclovir with 100 milligrams 5 times a day for a 7 to 10-day period. Other options such as famciclovir is also available. On the other hand, it is commonly combined with steroids, especially high-dose steroids such as prednisone, for about 3 weeks with a daily dose of 600 or 60 milligrams. And lastly, supportive therapy. As we know, Ramsay Hunt syndrome comes with a series of other diseases that involve a lot of different organs. One of the most common examples is vertigo. So what we can give is anti-vertigo drugs such as betahistine. On the other hand, for patients with the case of lagostalmus can be given artificial tears and also night taping, while lastly, patients with facial paralysis due to Ramsay Hunt syndrome can be slowly regained through physical rehabilitation.
Hello, my name is Juven Lufianto. Wilayah student ID number is 091. I will continue about the prognosis of Ramsay Hunt syndrome. Ramsay Hunt syndrome is self-limited, but it can cause some complication. The complication is depend on the severity of facial palsy or the lesion, and age. The younger patient is recover better than the elderly. And the last one is the comorbid that patient had. The recovery, the most patient recover completely from facial palsy, up to 1 year or several weeks if the patient is healthy and young. And the other complication, the patient may also develop synkinesis, post-herpetic neuralgia, and in some rare cases, the patient may also develop flaccid paralysis.
Hello everyone, my name is Anago with Parausa with student ID number 200251193. I would like to explain about the conclusion of this student project. So the definition is a disease caused by reactivation of the varicella zoster virus or VZV in the geniculate ganglion or facial nerve. The etiology caused by VZV, a double-stranded DNA containing virus better known as a human alpha herpes virus 3. And the pathophysiology start with the primary infection, of course, and then the VCP become lighted, and then reactivation of the VCP, and then reactivation in the geniculate ganglion in the facial. The clinical manifestation that can be found in the patient is red rash, facial paralysis, tinnitus, hearing loss, nausea, or even vomiting. The diagnosis you can use gold standard like clinical and physical examination only, and then the treatment there are few choices: antiviral such as acyclovir and steroids such as prednisone and supportive treatment. And the prognosis, the patient may have self-limited but can cause a complication.
So this is our references to our student project Ramsay Hunt syndrome. That's all from us. Thank you for your attention.